Welcome to this comprehensive continuing education course on osteoporosis, an evidence-based update designed specifically for physical therapists, occupational therapists, nurses, and allied health professionals. Over the course of this lecture, we will explore the latest developments in osteoporosis management, from the fundamental science of bone biology through to the practical applications of pharmacologic and non-pharmacologic interventions. By the end of this course, you will have the knowledge and clinical reasoning skills necessary to differentiate among treatment options, assess patient-specific risk factors, and integrate evidence-based strategies into individualized care plans. Let me begin by framing the scope of what we're dealing with. The human skeleton is a remarkably dynamic organ system that serves as the foundation for mobility, protection, and metabolic regulation throughout our entire lifespan. Osteoporosis represents one of the most prevalent and clinically consequential skeletal disorders that we encounter across rehabilitation and healthcare settings. Current estimates indicate that approximately 10 million Americans have osteoporosis, with an additional 44 million at elevated risk due to low bone mass. The clinical and economic burden of osteoporotic fractures is substantial. Hip fractures alone carry a one-year mortality rate of 21 to 24%. Many survivors experience permanent functional decline, loss of independence, and significantly diminished quality of life. For those of us in rehabilitation and allied health professions, osteoporosis is not merely a medical diagnosis managed by physicians and endocrinologists. Rather, it is a condition that directly intersects with our practice across acute, post-acute, and community settings. The landscape of osteoporosis management has evolved considerably in recent years. We've seen advances in fracture risk stratification, the emergence of anabolic-first treatment sequencing for very high-risk patients, updated screening guidelines, and growing recognition of health disparities that have reshaped evidence-based practice. Simultaneously, the foundational role of non-pharmacologic interventions, including targeted exercise, fall prevention, nutritional optimization, and lifestyle modification, has been reinforced by contemporary research. There is particular emphasis now on adherence challenges and the critical importance of multidisciplinary, team-based care models such as fracture liaison services. This course synthesizes the most current literature, drawing upon landmark guidelines, systematic reviews, meta-analyses, and clinical practice recommendations from organizations including the American College of Physicians, the Endocrine Society, the American Association of Clinical Endocrinology, and the Bone Health and Osteoporosis Foundation. Before we dive into the content, let me outline what you will be able to accomplish upon completion of this course. First, you will be able to differentiate between osteoporosis and osteopenia based on World Health Organization diagnostic criteria, bone mineral density, T-score thresholds, and clinical indicators of fragility fracture risk. Second, you will analyze the clinical utility of fracture risk assessment tools, including FRAX, in determining treatment thresholds and guiding pharmacologic intervention decisions for postmenopausal women and men with low bone mass. Third, you will compare the mechanisms of action, fracture risk reduction efficacy, and adverse effect profiles of anti-resorptive agents such as Bisphosphonates and Denosumab, alongside anabolic agents including teriparatide, abaloparatide, and romosozumab. Fourth, you will evaluate the evidence supporting anabolic-first treatment sequencing versus anti-resorptive-first strategies for patients at very high fracture risk, including considerations for optimal therapy duration and transition protocols. Fifth, you will assess the effectiveness of non-pharmacologic interventions, including calcium and vitamin D supplementation, weight-bearing and resistance exercise, and fall prevention strategies in reducing fracture risk and improving bone health outcomes across diverse patient populations. Sixth, you will determine appropriate osteoporosis management modifications for special populations, including patients with chronic kidney disease, diabetes mellitus, frailty, and those from underserved racial and ethnic groups affected by healthcare disparities. Finally, you will apply principles of multidisciplinary, team-based care, including fracture liaison services, nurse-led and pharmacist-led interventions, and caregiver support strategies to develop individualized plans that optimize adherence and clinical outcomes in patients with osteoporosis. Let's begin with the foundational science. Understanding the cellular and molecular mechanisms that govern bone remodeling provides the essential foundation for comprehending how osteoporosis develops and why specific therapeutic interventions are effective. For rehabilitation and allied health professionals, this foundational knowledge informs clinical reasoning, guides exercise prescription, and supports effective patient education regarding the nature of skeletal fragility and the rationale for both pharmacologic and non-pharmacologic interventions. Bone remodeling occurs through the coordinated activity of specialized cells operating within discrete anatomical units known as basic multicellular units. These units function across the skeletal surface throughout life. The three principal cell types involved in this process are osteoclasts, osteoblasts, and osteocytes, each contributing distinct and interdependent functions to the remodeling cycle. Osteoclasts are large, multinucleated cells derived from hematopoietic precursors that are responsible for bone resorption. This is the process by which mineralized bone matrix is broken down and its mineral content released into the circulation. These cells attach to bone surfaces and create sealed resorption lacunae. They secrete hydrochloric acid to dissolve the mineral component and proteolytic enzymes to degrade the organic collagen matrix. The activity of osteoclasts is tightly regulated by systemic hormones, local cytokines, and mechanical signals. The receptor activator of nuclear factor kappa B ligand, known as RANKL, and its decoy receptor osteoprotegerin, known as OPG, serve as critical molecular mediators of osteoclast differentiation and function. Osteoblasts are derived from mesenchymal stem cells and are responsible for bone formation. They synthesize and deposit the organic matrix components, predominantly type 1 collagen, that subsequently undergo mineralization to form new bone tissue. Following a period of active matrix synthesis, osteoblasts may undergo apoptosis, become quiescent bone lining cells on inactive surfaces, or become embedded within the mineralized matrix as osteocytes. Osteocytes represent the most abundant cell type in bone, comprising approximately 90% of all bone cells. They function as mechanosensors that detect mechanical strain and microdamage within the skeletal structure. These cells reside within lacunae and extend dendritic processes through canaliculi, forming an extensive intercellular network that enables communication with other osteocytes, bone-lining cells, and cells on the bone surface. Through this network, osteocytes orchestrate the targeted activation of remodeling in response to mechanical loading and accumulated damage. They secrete signaling molecules including sclerostin that regulate osteoblast activity and couple bone resorption to subsequent bone formation. Under healthy physiological conditions, bone resorption and bone formation are tightly coupled in both time and space. This means that the amount of bone removed by osteoclasts during resorption is precisely replaced by osteoblast-mediated formation. This coupling ensures that bone mass remains stable and that skeletal integrity is preserved, despite continuous turnover. However, when this equilibrium is disrupted, whether through hormonal changes, aging, nutritional deficiencies, inflammatory conditions, or other pathological states, a negative remodeling balance ensues. Bone resorption exceeds formation, resulting in progressive loss of bone mass and deterioration of microarchitecture. The cytokine environment within bone significantly influences this balance. Pro-inflammatory cytokines including interleukin-1, interleukin-6, and tumor necrosis factor alpha promote osteoclastogenesis and bone resorption while simultaneously inhibiting osteoblast differentiation and function. This inflammatory-mediated bone loss is particularly relevant in conditions such as rheumatoid arthritis, chronic kidney disease, and states of systemic inflammation, where cytokine dysregulation contributes to accelerated skeletal fragility. Now, let's establish the formal definition. Osteoporosis is defined as a systemic skeletal disorder characterized by low bone mass and microarchitectural deterioration of bone tissue, leading to enhanced bone fragility and a consequent increase in fracture risk. This definition emphasizes that osteoporosis involves not merely a reduction in the quantity of bone, but also qualitative changes in bone structure. These changes include trabecular thinning, loss of trabecular connectivity, and increased cortical porosity that compromise mechanical competence, independent of bone mineral density alone. The clinical significance of osteoporosis lies in its association with fragility fractures, which represent the principal adverse outcome of the disease and carry substantial morbidity, mortality, and healthcare costs. Fragility fractures are defined as fractures resulting from low-energy trauma, typically a fall from standing height or less, that would not cause fracture in healthy bone. The occurrence of such a fracture is itself diagnostic of osteoporosis and indicates the need for comprehensive evaluation and treatment, regardless of bone mineral density measurement results. The World Health Organization established the operational diagnostic criteria for osteoporosis in 1994, defining the condition based on bone mineral density measurement using dual-energy X-ray absorptiometry, commonly referred to as DXA. According to these criteria, osteoporosis is diagnosed when the BMD T-score at the lumbar spine, total hip, or femoral neck is equal to or less than negative 2.5 standard deviations below the mean BMD of a young adult reference population. The T-score represents the number of standard deviations by which an individual's measured BMD differs from the mean peak bone mass of healthy young adults of the same sex. This provides a standardized metric for comparison across populations and clinical settings. Osteopenia, representing an intermediate state of reduced bone mass that confers elevated fracture risk but does not meet the threshold for osteoporosis diagnosis, is defined as a T-score between negative 1.0 and negative 2.5. Normal bone density is indicated by a T-score of negative 1.0 or higher. These diagnostic categories provide a framework for risk stratification and treatment decision-making. However, clinicians must recognize that BMD represents only one component of fracture risk, and that substantial overlap exists in fracture occurrence across BMD categories. Dual-energy X-ray absorptiometry remains the gold standard for bone mineral density measurement due to its precision, low radiation exposure, widespread availability, and extensive validation in predicting fracture risk. The technique utilizes two X-ray beams of differing energy levels to distinguish between bone and soft tissue, allowing quantification of aerial bone mineral density expressed in grams per square centimeter. Standard measurement sites include the posterior anterior lumbar spine, typically L1 through L4, the total proximal femur, and the femoral neck. The lowest T-score among these sites is used for diagnostic classification. Each site offers distinct advantages and limitations. The lumbar spine provides high trabecular bone content and sensitivity to metabolic changes, but may be artifactually elevated by degenerative changes, aortic calcification, or vertebral compression fractures in older adults. The hip sites are less affected by degenerative artifacts and are particularly valuable for predicting hip fracture risk, which carries the highest morbidity and mortality among osteoporotic fractures. While the WHO criteria have proven invaluable for standardizing diagnosis and enabling comparison across studies and populations, important limitations must be acknowledged in clinical practice. The original reference data were derived primarily from postmenopausal white women. Although the criteria are now applied broadly across both sexes and all racial and ethnic groups, fracture risk at any given BMD level varies among populations. Additionally, bone mineral density accounts for only approximately 60 to 70% of bone strength. Factors such as bone geometry, microarchitecture, mineralization quality, and collagen cross-linking contribute to mechanical competence, but are not captured by DXA measurement. Consequently, many fractures occur in individuals with T-scores in the osteopenic rather than osteoporotic range. A substantial proportion of patients with very low BMD never experience fracture. This recognition has driven the development of clinical risk assessment tools that integrate BMD with independent clinical risk factors to provide more accurate fracture probability estimation. The concept of bone quality has emerged as an important complement to bone quantity in understanding skeletal fragility and fracture risk. Bone quality encompasses multiple properties that influence mechanical competence. These include trabecular architecture, meaning the thickness, number, and connectivity of trabecular elements, as well as cortical thickness and porosity, the degree and distribution of mineralization within the bone matrix, the accumulation and repair of microdamage, and the properties of the collagen matrix, including cross-link formation. Advanced imaging modalities such as high-resolution peripheral quantitative computed tomography and trabecular bone score derived from DXA images can provide additional information about bone microarchitecture. These may enhance fracture prediction beyond BMD alone in certain populations. However, these techniques are not yet widely available for routine clinical use, and standard DXA measurement remains the foundation of osteoporosis diagnosis in most practice settings. The clinical diagnosis of osteoporosis may also be established in the presence of a fragility fracture, regardless of BMD measurement results. Major osteoporotic fractures include those of the hip, clinical spine meaning symptomatic vertebral fractures, distal forearm or wrist, and proximal humerus or shoulder. Hip and vertebral fractures carry the greatest clinical consequences. Hip fractures are associated with significant acute morbidity, prolonged hospitalization, and mortality rates of 21 to 24% within the first year following fracture. Many survivors experience permanent functional decline and loss of independence. Vertebral compression fractures may present with acute back pain and height loss, or may occur silently without recognized symptoms. Yet even asymptomatic vertebral fractures substantially increase the risk of future vertebral and non-vertebral fractures. The occurrence of any fragility fracture indicates underlying skeletal compromise and warrants comprehensive evaluation and treatment initiation. This is because the risk of subsequent fracture is highest in the immediate period following an incident fracture, a concept termed imminent fracture risk that has important implications for treatment urgency and sequencing. Secondary causes of osteoporosis must be considered in the diagnostic evaluation, particularly when osteoporosis is identified in premenopausal women, men, or individuals with atypical presentations or inadequate response to therapy. Secondary osteoporosis refers to bone loss attributable to identifiable underlying conditions or medications rather than primary age-related or postmenopausal etiology. Common secondary causes include glucocorticoid therapy, which represents the most frequent cause of drug-induced osteoporosis. Glucocorticoids exert deleterious effects on bone through multiple mechanisms, including suppression of osteoblast function, enhancement of osteoclast survival, impairment of calcium absorption, and reduction of sex hormone production. Even relatively low doses of glucocorticoids, equivalent to 5 milligrams or more of prednisone daily for 3 months or longer, significantly increase fracture risk, often before substantial reductions in BMD are detectable. Other secondary causes include hypergonadism in both sexes, hyperparathyroidism, hyperthyroidism, malabsorption syndromes including celiac disease, inflammatory bowel disease, and post-bariatric surgery states, chronic kidney disease, chronic liver disease, rheumatoid arthritis, multiple myeloma, and use of medications such as aromatase inhibitors, androgen deprivation therapy, anticonvulsants, and proton pump inhibitors. Laboratory evaluation in patients with newly diagnosed osteoporosis or fragility fracture typically includes assessment of serum calcium, phosphorus, creatinine, alkaline phosphatase, 25-hydroxyvitamin D, complete blood count, and thyroid-stimulating hormone. Additional testing is guided by clinical suspicion for specific secondary causes. Serum protein electrophoresis may be indicated in older adults to evaluate for multiple myeloma. 24-hour urinary calcium measurement can identify absorptive or renal hypercalciuria as well as inadequate calcium intake. Bone turnover markers, including serum procollagen, type 1N terminal propeptide, known as P1NP, as a marker of bone formation, and serum C-terminal telepeptide of type 1 collagen, known as CTX, as a marker of resorption, may provide additional information regarding remodeling activity. These can be useful for monitoring treatment response, though they are not routinely required for diagnosis. For rehabilitation and allied health professionals, understanding the pathophysiology and diagnostic framework of osteoporosis enables effective clinical reasoning when evaluating patients with fragility fractures or elevated fracture risk. Recognizing that osteoporosis involves both quantitative bone loss and qualitative microarchitectural deterioration informs our appreciation of why exercise interventions that provide mechanical loading may stimulate bone formation through osteocyte-mediated mechanotransduction. It also helps us understand why fall prevention is critical, given that fragility fractures result from the combination of compromised bone strength and applied traumatic force. Knowledge of secondary causes supports identification of patients who may benefit from medical referral for further evaluation. Understanding of diagnostic criteria facilitates communication with referring physicians and interpretation of DXA reports. Now that we've established the foundational understanding of bone biology and diagnostic criteria, let's turn our attention to risk factors and fracture risk assessment. Effective osteoporosis management extends far beyond the measurement of bone mineral density to encompass comprehensive assessment of the multiple clinical factors that independently contribute to fracture risk. While DXA-based BMD measurement remains the cornerstone of osteoporosis diagnosis, clinical experience and epidemiological research have consistently demonstrated that fracture prediction improves substantially when BMD is integrated with other established risk factors. For those of us who frequently encounter patients with osteoporosis or elevated fracture risk, thorough understanding of these risk factors enables more accurate identification of individuals who may benefit from intervention. It supports informed clinical decision-making regarding exercise prescription and fall prevention strategies, and it facilitates meaningful communication with patients about their personal risk profile and the rationale for recommended interventions. The risk factors for osteoporosis and fragility fracture are multifactorial and may be broadly categorized as non-modifiable factors inherent to the individual and modifiable factors amenable to intervention. Among the non-modifiable risk factors, advancing age stands as the strongest determinant of fracture risk, exerting effects that are independent of bone mineral density. The relationship between age and fracture risk reflects multiple physiological changes that accumulate over the lifespan. These include progressive bone loss that accelerates in women following menopause, deterioration of bone microarchitecture, even when BMD remains relatively stable, sarcopenia with associated muscle weakness and impaired balance, and increased fall propensity due to decline in neuromuscular function, visual impairment, and comorbid conditions. The magnitude of age-related fracture risk is substantial. A 70-year-old woman with a given BMD has approximately double the fracture risk of a 50-year-old woman with identical BMD. This underscores the importance of considering age as an independent risk factor rather than relying solely on densitometric assessment. Female sex and postmenopausal status represent additional non-modifiable risk factors that substantially influence fracture probability. Women experience accelerated bone loss during the perimenopausal transition and early postmenopausal years due to estrogen deficiency, which removes the restraining influence of estrogen on osteoclast activity and bone resorption. This accelerated phase of bone loss may result in decrements of 2 to 3% per year at the spine and 1 to 2% per year at the hip during the first 5 to 10 years following menopause. This contributes to the higher lifetime fracture risk observed in women compared to men. Premature menopause, occurring before age 40 years, and surgical menopause without hormone replacement further amplify this risk by extending the duration of estrogen deficiency. While osteoporosis has historically been considered primarily a disease of postmenopausal women, growing recognition of substantial fracture burden in men has prompted increased attention to screening and treatment in male populations. Personal history of fragility fracture is among the most powerful predictors of future fracture, conferring risk that is largely independent of BMD and substantially exceeds that predicted by densitometry alone. An individual who has sustained a fragility fracture has approximately double the risk of subsequent fracture compared to someone of similar age and BMD who has not experienced prior fracture. This elevated risk persists for many years following the index event. The predictive value of prior fracture applies across fracture sites. A history of wrist fracture, vertebral fracture, or other osteoporotic fracture increases risk for future hip, spine, and other fractures. Importantly, the risk of subsequent fracture is highest in the immediate period following an incident fracture. This concept, now termed imminent fracture risk, has significant implications for treatment urgency. Studies demonstrate that approximately 20% of patients who sustain a fragility fracture will experience another fracture within the subsequent 2 years, with the highest risk concentrated in the first 12 months. This recognition has driven guideline recommendations for prompt initiation of pharmacologic therapy, and particularly consideration of anabolic agents in patients with recent fracture who are at very high risk for subsequent events. Parental history of hip fracture, particularly maternal hip fracture, represents a well-established genetic risk factor that contributes to fracture probability independent of measured BMD. This familial aggregation reflects the substantial heritability of bone mass and skeletal geometry. Genetic factors are estimated to account for 60 to 80% of the variance in peak bone mass and make significant contributions to bone loss trajectories, bone quality parameters, and fall propensity. While specific genetic variants have been identified through genome-wide association studies, the clinical utility of genetic testing for osteoporosis risk assessment remains limited. Family history serves as a practical surrogate for inherited skeletal vulnerability in routine clinical practice. Modifiable risk factors present opportunities for intervention and represent important targets for patient education and clinical management. Low body weight, typically defined as body mass index below 20 kilograms per square meter or body weight below 58 kilograms, is associated with reduced mechanical loading on the skeleton, lower fat mass with diminished peripheral estrogen conversion, and inadequate nutritional reserves. All of these contribute to compromised bone health. Current cigarette smoking accelerates bone loss through multiple mechanisms, including direct toxic effects on osteoblasts, altered calcium and vitamin D metabolism, earlier menopause in women, and association with lower body weight and reduced physical activity. The detrimental effects of smoking on bone are at least partially reversible with cessation, providing strong rationale for smoking cessation counseling as a component of comprehensive osteoporosis management. Excessive alcohol consumption, generally defined as 3 or more drinks daily, adversely affects bone through direct suppression of osteoblast function, nutritional compromise, increased fall risk due to impaired balance and coordination, and chronic liver disease with associated metabolic derangements. Moderate alcohol intake does not appear to significantly affect fracture risk and may even be associated with modest benefit in some observational studies, though this potential benefit does not justify alcohol consumption for bone health purposes. Physical inactivity contributes to osteoporosis risk through loss of the anabolic stimulus that mechanical loading provides to bone. It also contributes through sarcopenia, reduced balance and coordination, and increased fall susceptibility. Conversely, regular weight-bearing and resistance exercise throughout the lifespan supports attainment of optimal peak bone mass in youth, maintenance of bone mass in adulthood, and attenuation of bone loss in older age. Simultaneously, exercise improves muscle strength, balance, and fall prevention. Nutritional factors, particularly calcium and vitamin D status, influence bone health and fracture risk. Inadequate calcium intake limits the substrate available for bone mineralization and may trigger secondary hyperparathyroidism, with consequent acceleration of bone resorption to maintain serum calcium homeostasis. Vitamin D deficiency impairs intestinal calcium absorption, contributes to secondary hyperparathyroidism, and may independently affect muscle function and fall risk. While the optimal serum 25-hydroxyvitamin D concentration for bone health remains debated, most guidelines recommend maintaining levels above 20 to 30 nanograms per milliliter, with supplementation as needed to achieve this target in individuals with inadequate dietary intake or limited sun exposure. Several medical conditions and medications are associated with secondary osteoporosis and elevated fracture risk. As I mentioned earlier, long-term glucocorticoid therapy represents the most common cause of drug-induced osteoporosis, with fracture risk increasing rapidly after initiation and occurring at higher BMD levels than in primary osteoporosis. Rheumatoid arthritis confers fracture risk through inflammatory cytokine-mediated bone loss, glucocorticoid use, reduced mobility, and disease-related disability. Type 2 diabetes mellitus is paradoxically associated with increased fracture risk despite often normal or elevated BMD. This reflects adverse effects of hyperglycemia, advanced glycation end products, and diabetic complications on bone quality. Chronic kidney disease, particularly in advanced stages, disrupts mineral metabolism and leads to complex bone disorders with elevated fracture risk. These secondary causes require consideration in risk assessment and may influence treatment selection. The recognition that BMD alone incompletely captures fracture risk led to development of the Fracture Risk Assessment Tool, known as FRAX. This tool integrates clinical risk factors with or without BMD to estimate the 10-year probability of hip fracture and major osteoporotic fracture. FRAX was developed using primary data from prospective population-based cohorts across multiple countries and has been validated in numerous independent populations. It is now established as the most widely used fracture risk assessment instrument globally. The tool incorporates 11 clinical risk factors: age, sex, weight, height, previous fracture, parental history of hip fracture, current smoking, glucocorticoid use, rheumatoid arthritis, secondary osteoporosis, and alcohol intake of 3 or more units daily. There is optional inclusion of femoral neck BMD. Country-specific versions account for differences in baseline fracture rates and mortality across populations, enabling locally calibrated risk estimation. FRAX outputs include the 10-year probability of hip fracture and the 10-year probability of major osteoporotic fracture. The latter encompasses fractures of the hip, clinical spine, forearm, and proximal humerus. These probabilities inform treatment decisions by enabling comparison against intervention thresholds established by professional organizations and guideline bodies. In the United States, the National Osteoporosis Foundation and subsequent Bone Health and Osteoporosis Foundation guidelines have recommended pharmacologic treatment when the 10-year probability of hip fracture reaches or exceeds 3%, or when the 10-year probability of major osteoporotic fracture reaches or exceeds 20%. These thresholds were derived from cost-effectiveness analyses and represent the fracture probability at which pharmacologic intervention becomes economically justified based on medication costs and fracture prevention efficacy. Alternative threshold approaches have been proposed, including age-dependent thresholds that acknowledge the increasing baseline risk with advancing age, and hybrid approaches that integrate FRAX probability with BMD categories. Despite its widespread adoption and clinical utility, FRAX has recognized limitations that clinicians must consider when interpreting results and making treatment decisions. The tool provides a point estimate of fracture probability but cannot account for all factors that influence individual risk. Several conditions known to affect fracture probability are not included in the algorithm. For example, fall history, which is a powerful predictor of fracture, particularly at non-vertebral sites, is not incorporated into FRAX. Similarly, the tool does not account for dose-response relationships for variables such as glucocorticoid exposure, smoking, and alcohol intake. Instead, it treats these as dichotomous, present or absent risk factors. Recent fracture is weighted equally to remote fracture in the algorithm, despite evidence that imminent fracture risk is substantially higher following recent events. Additionally, FRAX was developed using femoral neck BMD, and does not accommodate lumbar spine measurements, which may identify individuals with predominantly trabecular bone loss that would be missed by femoral neck assessment alone. The use of race and ethnicity adjustments in FRAX has generated important discussion regarding potential contributions to healthcare disparities. The United States version of FRAX includes separate calculations for white, Black, Hispanic, and Asian populations, reflecting observed differences in fracture rates among these groups. However, applying race-specific calculations may result in lower calculated fracture probabilities for Black and Hispanic patients, potentially leading to less frequent treatment recommendations despite substantial fracture, morbidity, and mortality in these populations. Recent guidelines have encouraged clinicians to consider these limitations when applying FRAX in diverse populations and to recognize that race-specific adjustments may perpetuate undertreatment of minority groups who already experience disparities in osteoporosis screening and management. Several modifications and supplements to standard FRAX calculation have been proposed to enhance fracture prediction in specific circumstances. Trabecular bone score, a textural index derived from lumbar spine DXA images that provides information about trabecular microarchitecture, can be incorporated into FRAX calculation to adjust fracture probability. This is particularly useful in patients with conditions that affect bone quality disproportionate to BMD, such as diabetes, mellitus, and glucocorticoid-treated patients. Adjustments for high-dose glucocorticoid exposure, multiple fractures, and lumbar spine, BMD, substantially lower than femoral neck BMD, have also been proposed to address specific clinical scenarios where standard FRAX may underestimate risk. The concept of imminent fracture risk has emerged as a critical consideration in contemporary risk assessment and treatment decision-making. Imminent risk refers to the elevated probability of fracture in the near term, typically defined as the subsequent 1 to 2 years, that characterizes patients with recent fragility fracture, very low BMD, multiple vertebral fractures, or fracture while receiving osteoporosis therapy. Recognition that fracture risk is not uniformly distributed over the 10-year FRAX horizon, but rather concentrated in the early period following index events, has driven recommendations for expedited treatment initiation and consideration of anabolic agents. Anabolic agents provide more rapid fracture risk reduction than anti-resorptive therapy alone. The position statement on goal-directed osteoporosis treatment from the ASBMR and BHOF task force has emphasized identification of very high-risk patients who may benefit from initial anabolic therapy followed by anti-resorptive consolidation. This represents a paradigm shift from earlier approaches that reserved anabolic agents for treatment failures. Integration of full risk assessment into osteoporosis evaluation represents an essential component of comprehensive fracture prevention. Most fragility fractures result from falls, and addressing fall risk provides an important complement to skeletal-directed interventions. Fall risk factors overlap substantially with osteoporosis risk factors and include advanced age, female sex, prior falls, muscle weakness, gait and balance impairment, visual deficits, cognitive impairment, polypharmacy, particularly involving psychotropic medications, environmental hazards, and comorbid conditions such as Parkinson's disease, stroke, and peripheral neuropathy. Rehabilitation and allied health professionals are uniquely positioned to assess fall risk through clinical examination of strength, balance, gait, and functional mobility. We can implement targeted interventions including exercise programs, environmental modifications, and medication review recommendations. The integration of full risk assessment with skeletal risk assessment enables comprehensive fracture prevention planning that addresses both bone fragility and the mechanical forces applied to the skeleton through falls. Current screening recommendations from the United States Preventive Services Task Force endorse bone mineral density screening for all women aged 65 years and older. Screening is also recommended for postmenopausal women younger than 65 years, whose 10-year fracture risk, as assessed by clinical risk factors, equals or exceeds that of a 65-year-old white woman without additional risk factors. This risk-based approach for younger postmenopausal women acknowledges that fracture probability varies substantially based on clinical risk factors. Screening based solely on age would miss some higher-risk individuals while subjecting lower-risk individuals to potentially unnecessary testing. For men, evidence regarding screening benefit is less robust, and the USPSTF has concluded that current evidence is insufficient to assess the balance of benefits and harms of screening in men. However, other professional organizations, including the Bone Health and Osteoporosis Foundation and the Endocrine Society, recommend screening men at age 70 years or older, as well as younger men with clinical risk factors for osteoporosis. For rehabilitation and allied health professionals, practical application of risk assessment principles involves recognition of clinical scenarios that warrant concern for elevated fracture risk, appropriate referral for densitometry, and medical evaluation when indicated, and integration of risk assessment findings into therapeutic planning. Patients presenting with fragility fractures, height loss suggestive of vertebral compression, kyphotic postural changes, or multiple risk factors merit comprehensive evaluation. When DXA and FRAX results are available, understanding of T-score interpretation and fracture probability thresholds enables informed discussion with patients and collaboration with referring providers. Recognition of very high-risk patients who may be candidates for anabolic-first pharmacologic strategies supports timely referral and treatment initiation. Throughout the assessment process, attention to modifiable risk factors, including physical inactivity, fall risk, smoking, excessive alcohol intake, and nutritional deficiencies identifies targets for intervention that fall within the scope of rehabilitation practice and patient education. Now, let's turn to one of the most clinically important sections of this course, pharmacologic management. Pharmacologic therapy represents a cornerstone of osteoporosis management for patients at elevated fracture risk. Contemporary evidence demonstrates substantial reductions in vertebral, hip, and non-vertebral fractures across multiple medication classes. For rehabilitation and allied health professionals, understanding the mechanisms, efficacy, adverse effects, and sequencing considerations of osteoporosis medications enables effective patient education, recognition of treatment-related concerns, and informed collaboration with prescribing providers. Pharmacologic treatment is indicated for patients with osteoporosis defined by T-score at or below -2.5 at the lumbar spine, femoral neck, or total hip. It is also indicated for patients with hip or vertebral fracture, regardless of BMD measurement results. Treatment is additionally recommended for patients with osteopenia, meaning T-scores between -1.0 and -2.5 when fracture risk assessment using FRAX indicates 10-year probability of major osteoporotic fracture at or above 20%, or hip fracture probability at or above 3%. These treatment thresholds reflect cost-effectiveness analyses, demonstrating favorable benefit to risk ratios when pharmacologic intervention is initiated at these fracture probability levels. The selection of specific pharmacologic agents depends upon fracture risk severity, patient comorbidities, contraindications, preferences, and considerations of treatment sequencing that have evolved substantially in recent guidelines. Bisphosphonates represent the most extensively studied and widely prescribed class of osteoporosis medications, with decades of clinical trial evidence supporting their efficacy in reducing fracture risk. These agents share a common mechanism of action based on their high affinity for hydroxyapatite mineral in bone. This leads to their incorporation into the skeletal matrix where they are released during osteoclastic bone resorption. Once taken up by osteoclasts, bisphosphonates inhibit farnesyl pyrophosphate synthase, an enzyme in the mevalonate pathway essential for osteoclast function and survival. This ultimately induces osteoclast apoptosis and reduces bone resorption. The net effect is a positive shift in the remodeling balance, with bone formation exceeding resorption during the initial years of treatment. This results in gains in bone mineral density and reduction in fracture risk. Oral bisphosphonates available for osteoporosis treatment include alendronate, typically dosed at 70 mg weekly, and risdronate, typically 35 mg weekly or 150 mg monthly. Intravenous formulations include zoledronic acid, 5 mg administered annually, and abandronate, 3 mg every 3 months. Clinical trials have demonstrated that oral alendronate and risdronate reduce vertebral fracture risk by approximately 40 to 50% and hip fracture risk by 40 to 50% over 3 to 4 years of treatment in women with established osteoporosis. Zoledronic acid has shown similar efficacy, with the Horizon trial demonstrating 70% reduction in vertebral fractures and 41% reduction in hip fractures over 3 years. The convenience of annual intravenous administration with zoledronic acid offers potential adherence advantages compared with the complex administration requirements of oral bisphosphonates. Oral bisphosphonates must be taken on an empty stomach with a full glass of water, followed by remaining upright for 30 to 60 minutes to minimize esophageal irritation. The gastrointestinal adverse effects of oral bisphosphonates, including esophagitis, dyspepsia, and abdominal pain, represent the most common tolerability concerns. These effects contribute to the high rates of discontinuation observed in clinical practice. Proper administration technique is essential to minimize these effects. Patients should be counseled thoroughly regarding the importance of taking oral bisphosphonates with plain water only, not coffee, juice, or other beverages. They should remain upright and wait the recommended interval before eating or taking other medications. Bisphosphonates are contraindicated in patients with esophageal abnormalities that delay emptying, inability to remain upright, hypocalcemia, and severe renal impairment with creatinine clearance below 30 to 35 milliliters per minute. Acute phase reactions including fever, myalgias, and arthralgias may occur following intravenous bisphosphonate administration, particularly with the first dose. These typically resolve within several days and can be managed with acetaminophen or nonsteroidal anti-inflammatory drugs. Denosumab is a fully human monoclonal antibody that binds to RANKL, thereby preventing its interaction with RANK on osteoclast precursors and mature osteoclasts. By blocking RANKL, denosumab potently inhibits osteoclast differentiation, function, and survival. This results in marked suppression of bone resorption and increases in bone mineral density that are generally larger than those achieved with bisphosphonates. Denosumab is administered as a 60 mg subcutaneous injection every 6 months. This offers a convenient dosing schedule that eliminates the gastrointestinal concerns and complex administration requirements of oral bisphosphonates. Clinical trials have demonstrated that Denosumab reduces vertebral fracture risk by approximately 68%, hip fracture risk by 40%, and non-vertebral fracture risk by 20% over 3 years of treatment. Unlike bisphosphonates, which accumulate in bone and provide residual anti-resorptive effect after discontinuation, Denosumab's effects are fully reversible upon cessation of therapy. This reversibility creates a significant clinical challenge. Discontinuation of Denosumab is associated with rapid rebound in bone turnover markers to levels exceeding pretreatment values, accelerated bone loss, and markedly elevated risk of multiple vertebral fractures. The rebound phenomenon appears related to the persistence of osteoclast precursors that are not eliminated by rankle inhibition. These precursors rapidly differentiate into active osteoclasts when Denosumab effect wanes. Consequently, patients discontinuing Denosumab require transition to bisphosphonate therapy to prevent rebound bone loss and fractures. Zoledronic acid administered 6 months after the last Denosumab dose represents the most commonly recommended approach. This transition requirement has important implications for patient selection and counseling, as Denosumab effectively commits patients to long-term anti-resorptive therapy. Denosumab does not accumulate in the kidney and is not contraindicated in patients with renal impairment. This makes it an attractive option for patients with chronic kidney disease in whom bisphosphonates may be contraindicated or require dose adjustment. However, the risk of hypocalcemia is increased in patients with CKD. Careful attention to calcium and vitamin D supplementation with monitoring of serum calcium is essential, particularly in patients with advanced CKD. Other adverse effects associated with Denosumab include skin reactions at the injection site and, rarely, osteonecrosis of the jaw and atypical femoral fractures. Now let's discuss anabolic agents, which represent a distinct pharmacologic approach that stimulates bone formation rather than inhibiting resorption. This results in net addition of new bone tissue and improvements in bone microarchitecture. 3 anabolic agents are currently approved for osteoporosis treatment: teriparatide, abaloparatide, and romosozumab. Teriparatide is a recombinant form of the amino-terminal fragment of human parathyroid hormone. Abaloparatide is a synthetic analog of parathyroid hormone-related protein. Both act through the PTH1 receptor to stimulate osteoblast activity when administered intermittently. Romosozumab is a monoclonal antibody that binds and inhibits sclerostin, a protein secreted by osteocytes that normally inhibits bone formation. By blocking sclerostin, romosozumab stimulates osteoblast-mediated bone formation while simultaneously reducing bone resorption. This provides a unique dual mechanism of action. Teriparatide is administered as a 20 microgram daily subcutaneous injection for up to 24 months. Clinical trials have demonstrated 65% reduction in vertebral fractures and 53% reduction in non-vertebral fractures. Abaloparatide is administered as an 80 microgram daily subcutaneous injection, also for up to 24 months. It has shown 86% reduction in vertebral fractures and 43% reduction in non-vertebral fractures in clinical trials. Both agents produce substantial increases in bone mineral density, particularly at the lumbar spine. They improve trabecular microarchitecture in ways that contribute to fracture risk reduction beyond BMD effects. Common adverse effects include hypercalcemia, which is more frequent with teriparatide, as well as nausea, dizziness, and leg cramps. Both carry black box warnings regarding osteosarcoma risk based on rat studies, though this risk has not been confirmed in humans despite extensive post-marketing surveillance. Romosozumab is administered as 2 concurrent 105 mg subcutaneous injections, totaling 210 mg monthly for 12 months. The FRAME trial demonstrated 73% reduction in vertebral fractures and 36% reduction in clinical fractures over 12 months of romosozumab treatment followed by Denosumab, compared with placebo followed by Denosumab. The ARCH trial compared romosozumab followed by alendronate versus alendronate alone in women with severe osteoporosis. It demonstrated 50% reduction in vertebral fractures and significant reductions in clinical and non-vertebral fractures with the sequential romosozumab approach. Romosozumab produces rapid and substantial gains in bone mineral density, with increases of approximately 13% at the lumbar spine and 7% at the total hip over 12 months. However, cardiovascular safety concerns emerged from the ARCH trial, which showed a numerical imbalance in serious cardiovascular events in the romosozumab group compared with alendronate. Subsequent meta-analyses and real-world studies have produced mixed results regarding cardiovascular risk, with some suggesting increased risk and others finding no significant difference. Current prescribing information includes a black box warning advising against romosozumab use in patients who have had myocardial infarction or stroke within the preceding year. Careful cardiovascular risk assessment is recommended before initiating therapy. For patients without recent cardiovascular events who are at very high fracture risk, the substantial fracture reduction benefits of romosozumab may outweigh potential cardiovascular concerns. However, individualized risk-benefit assessment is essential. The concept of treatment sequencing has emerged as a fundamental consideration in contemporary osteoporosis management. This is driven by recognition that the order in which agents are used affects clinical outcomes. The traditional approach of reserving anabolic agents for patients who have failed anti-resorptive therapy has been challenged by evidence demonstrating that prior anti-resorptive treatment blunts the subsequent response to anabolic agents. When teriparatide or abaloparatide are initiated in patients previously treated with bisphosphonates or denosumab, the bone mineral density gains are smaller and achieved more slowly than in treatment-naive patients. Conversely, initiating anabolic therapy first in treatment-naive patients produces robust BMD gains that are then consolidated and maintained by subsequent anti-resorptive therapy. The position statement on goal-directed osteoporosis treatment has recommended consideration of anabolic-first sequencing for patients at very high fracture risk. These are patients with recent vertebral or hip fracture, multiple vertebral fractures, very low T-scores below -3.0, high, frax probability, or fracture occurring during osteoporosis treatment. In these very high-risk patients, the more rapid and substantial fracture risk reduction achieved with anabolic agents provides clinical benefit that may not be achievable with anti-resorptive therapy alone. Following completion of anabolic therapy, which is 24 months for teriparatide or abaloparatide and 12 months for romosozumab, transition to anti-resorptive therapy with a bisphosphonate or denosumab is essential. This consolidates BMD gains and maintains long-term fracture protection. The duration of pharmacologic treatment and the role of drug holidays require careful consideration, particularly for bisphosphonates, whose skeletal accumulation provides residual benefit after discontinuation. Guidelines generally recommend reassessment after 3 to 5 years of bisphosphonate therapy. Consideration of the drug holiday may be appropriate in patients who have achieved stable BMD, have not experienced incident fractures, and are not at very high fracture risk. During a bisphosphonate holiday, the residual drug in bone continues to provide some protection against bone loss and fracture, though this effect wanes over time. Monitoring with BMD measurement every 2 to 3 years and resumption of treatment if BMD declines substantially or fracture occurs is recommended. For patients at very high fracture risk, continuous treatment without holiday is generally preferred given the elevated risk of fracture during treatment interruption. As I noted earlier, denosumab does not permit true drug holidays due to rebound bone loss upon discontinuation. Patients receiving denosumab generally require indefinite treatment or planned transition to bisphosphonate therapy. Rare but serious adverse effects associated with long-term anti-resorptive therapy include osteonecrosis of the jaw and atypical femoral fractures. Osteonecrosis of the jaw involves exposed bone in the oral cavity that fails to heal, occurring most commonly following dental extraction or other invasive dental procedures. The risk in osteoporosis patients receiving standard anti-resorptive doses is estimated at 1 per 10,000 to 1 per 100,000 patient years. This is substantially lower than in cancer patients receiving high-dose therapy. Preventive dental care and completion of needed dental work before initiating anti-resorptive therapy can reduce this risk. Atypical femoral fractures are stress fractures occurring in the subtrochanteric or femoral shaft region with characteristic transverse or short oblique configuration. They are often preceded by prodromal thigh or groin pain. The risk increases with duration of bisphosphonate therapy, estimated at approximately 1 to 10 per 10,000 patient years with extended use beyond 5 years. The absolute risk of atypical femoral fractures remains low compared with the fractures prevented by anti-resorptive therapy. However, awareness of prodromal symptoms and consideration of drug holidays in appropriate patients can mitigate this risk. For rehabilitation and allied health professionals, understanding of pharmacologic management supports effective patient education regarding medication mechanisms, expected benefits, proper administration, particularly for oral bisphosphonates, and recognition of adverse effects. Knowledge of treatment sequencing considerations enables informed communication with prescribing providers and supports appropriate identification of very high-risk patients who may benefit from anabolic-first approaches. Recognition that pharmacologic therapy is typically long-term and that adherence challenges are common highlights the importance of the multidisciplinary adherence strategies we will discuss shortly. Throughout the therapeutic relationship, rehabilitation professionals can reinforce medication adherence, monitor for treatment concerns, and ensure that pharmacologic and non-pharmacologic interventions are integrated into comprehensive fracture prevention plans. Now let's shift our focus to non-pharmacologic management and lifestyle interventions. These interventions constitute essential components of comprehensive osteoporosis management, addressing modifiable factors that influence bone health, fall risk, and fracture outcomes. For rehabilitation and allied health professionals, these interventions represent primary domains of clinical practice and offer substantial opportunities to improve patient outcomes through evidence-based approaches to nutrition, exercise, fall prevention, and lifestyle modification. Let's begin with calcium and vitamin D. Adequate calcium and vitamin D intake support bone health by providing the mineral substrate for skeletal formation and the hormonal environment necessary for efficient calcium absorption and utilization. Calcium recommendations for adults with osteoporosis or at elevated fracture risk typically range from 1,000 to 1,200 milligrams daily from dietary sources and supplements combined. The higher end of this range is recommended for postmenopausal women and older adults. Dietary calcium sources including dairy products, calcium-fortified foods, and certain vegetables such as kale, broccoli, and bok choy are generally preferred over supplements when feasible. They provide calcium in a food matrix that may optimize absorption and utilization while avoiding potential risks associated with high-dose supplementation. When dietary intake is insufficient, calcium supplements in the form of calcium carbonate, which requires gastric acid for absorption and should be taken with meals, or calcium citrate, which is absorbed independently of gastric acid and may be taken without food, can address the shortfall. Vitamin D recommendations for osteoporosis patients typically suggest intake of 800 to 2,000 international units daily, with the goal of achieving and maintaining serum 25-hydroxyvitamin D concentrations above 20 to 30 nanograms per milliliter. Vitamin D3, known as cholecalciferol, is generally preferred over vitamin D2, known as ergocalciferol, due to greater potency and longer duration of action. Patients with documented deficiency may require higher loading doses to achieve repletion before transitioning to maintenance supplementation. Factors that increase vitamin D requirements or limit synthesis include limited sun exposure, darker skin pigmentation, obesity with vitamin D sequestration in adipose tissue, malabsorption syndromes, and certain medications. The relationship between vitamin D supplementation and fracture prevention has been the subject of considerable investigation. Meta-analyses and recent large trials have produced nuanced findings. The VITAL trial randomized over 25,000 generally healthy adults to 2,000 international units of vitamin D, 3 daily or placebo, and followed them for a median of 5.3 years. It found no significant reduction in fracture incidence with vitamin D supplementation. However, the study population was largely vitamin D replete at baseline, with mean serum 25-hydroxyvitamin D, approximately 31 nanograms per milliliter. Participants were not selected for osteoporosis or elevated fracture risk. In contrast, meta-analyses of studies in populations with vitamin D deficiency, particularly institutionalized older adults, and those with documented osteoporosis, have demonstrated fracture reduction benefits, especially when vitamin D is combined with calcium supplementation. Current guideline recommendations emphasize that calcium and vitamin D are foundational components of osteoporosis management that should accompany pharmacologic therapy. However, They acknowledge that supplementation alone is insufficient to prevent fractures in high-risk patients. Potential risks associated with calcium supplementation have been debated. Some observational studies and meta-analyses have suggested associations with cardiovascular events and nephrolithiasis. The evidence regarding cardiovascular risk remains inconsistent, and most guideline bodies conclude that calcium intake from food and supplements up to 1,200 to 1,500 milligrams daily does not significantly increase cardiovascular risk. Nephrolithiasis risk appears more established, particularly with higher supplemental calcium doses. Patients with history of kidney stones may benefit from preferential reliance on dietary calcium and consideration of lower total calcium intake. These considerations support recommendations for achieving calcium needs through dietary sources when possible and limiting supplemental calcium to the amount needed to reach but not substantially exceed recommended intake levels. Now let's discuss exercise interventions, which represent a fundamental non-pharmacologic approach to osteoporosis management. Exercise effects are mediated through mechanotransduction, which is the process by which mechanical loading stimulates bone formation. They also work through improvements in muscle strength and mass-addressing sarcopenia, and through enhancements in balance and coordination that reduce fall risk. The principle of mechanotransduction holds that osteocytes sense mechanical strain applied to the skeleton and respond by signaling for increased bone formation. The magnitude and frequency of strain determine the adaptive response. Exercise modalities that provide high impact or high strain loading stimuli generally produce greater osteogenic effects than low impact activities. However, the exercise prescription must be individualized based on patient functional status, fracture history, comorbidities, and preferences. Systematic reviews and meta-analyses have examined the effects of exercise on bone mineral density in postmenopausal women and older adults, generally demonstrating modest but clinically meaningful benefits. A comprehensive meta-analysis of exercise interventions in postmenopausal women found that combined weight-bearing aerobic exercise and progressive resistance training produced BMD improvements of approximately 1 to 3% at the lumbar spine, and hip over exercise periods ranging from 6 to 24 months. Resistance training appears particularly important for both bone and muscle outcomes. Moderate to vigorous intensity and progressive loading produce greater effects than low-intensity programs. Weight-bearing aerobic activities including walking, jogging, stair climbing, and dancing provide osteogenic stimulus, primarily to the lower extremity and spine. Resistance training can target multiple skeletal regions, including the hip, spine, and wrist. The optimal exercise prescription for osteoporosis management incorporates multiple components addressing bone health, muscle strength, balance, and functional capacity. Current recommendations emphasize multi-component programs that include weight-bearing aerobic activities such as walking, jogging, or aerobic exercise classes on most days of the week. They also include progressive resistance training targeting major muscle groups at least 2 to 3 days per week at moderate to vigorous intensity, and balance and postural exercises to reduce fall risk and address kyphotic changes. For patients with vertebral fractures or significant kyphosis, spine-specific considerations apply. Exercises involving loaded spinal flexion or rotation should be avoided due to increased vertebral stress. Extension exercises, postural training, and core strengthening within safe ranges can improve pain, posture, and function. Implementation of exercise interventions requires attention to safety considerations, progression principles, and adherence strategies. Patients with severe osteoporosis, recent fracture, or significant comorbidities may require initial assessment and supervised exercise prescription by physical therapists or exercise physiologists with expertise in osteoporosis management. Progression should follow established principles of graduated loading, with increases in intensity, duration, or complexity implemented incrementally as tolerance permits. Common barriers to exercise adherence include pain, fear of falling or fracture, lack of access to appropriate programs, competing time demands, and insufficient motivation. Addressing these barriers through individualized education, supervised programs, group-based social support, and regular follow-up can enhance long-term participation. Fall prevention represents a critical component of fracture risk reduction. Approximately 95% of hip fractures and a substantial proportion of other osteoporotic fractures result from falls. Fall risk assessment in older adults evaluates multiple domains, including gait and balance, muscle strength, vision, cognition, medications, particularly psychotropic drugs, antihypertensives, and polypharmacy, environmental hazards, and comorbid conditions that affect stability. Standardized assessment tools, including the Timed Up and Go test, Berg Balance Scale, and multifactorial fall risk assessment protocols, can identify individuals at elevated risk and guide intervention selection. The evidence base for fall prevention interventions has been evaluated in multiple systematic reviews. Exercise interventions, particularly those including balance training, gait training, and strength training, reduce fall rates by approximately 13% in community-dwelling older adults. Greater effects are observed for high-risk populations and programs that include balance-challenging activities. Tai Chi, group-based exercise programs, and individually tailored physical therapy interventions have demonstrated efficacy in reducing falls. Multifactorial interventions that combine exercise with medication review, vision assessment and correction, home safety evaluation and modification, and management of medical conditions affecting balance appear effective for individuals at high fall risk, identified through comprehensive assessment. Medication review as a component of fall prevention addresses the well-established association between certain medication classes and fall risk. Psychotropic medications including benzodiazepines, sedative hypnotics, antidepressants, and antipsychotics significantly increase fall risk through effects on alertness, balance, and orthostatic blood pressure. Anticholinergic medications contribute to fall risk through cognitive effects and may be particularly problematic in older adults. Cardiovascular medications, including antihypertensives and diuretics, can cause orthostatic hypertension and syncope. Deprescribing of high-risk medications when clinically appropriate, dose reduction, and substitution with lower-risk alternatives represent important strategies that rehabilitation professionals can support through collaboration with prescribing providers. Environmental modification and home safety assessment address the physical environment in which falls occur. Common environmental hazards include loose rugs, cluttered walkways, inadequate lighting, lack of handrails on stairs, bathroom hazards such as slippery surfaces, and absence of grab bars, and unstable furniture. Home safety evaluations conducted by occupational therapists or trained assessors can identify specific hazards and recommend modifications tailored to individual patient circumstances. Evidence supports the effectiveness of home safety interventions, particularly when delivered by occupational therapists and targeted to individuals at elevated fall risk. Lifestyle modifications beyond exercise address additional modifiable risk factors that influence bone health and fall risk. Smoking cessation provides benefits for bone through elimination of the direct toxic effects of tobacco on osteoblasts, improvement in vitamin D metabolism, and potential gains in body weight and nutritional status. Patients who smoke should receive cessation counseling and support, with recognition that bone benefits accrue gradually following cessation. Moderation of alcohol consumption to no more than 2 drinks daily for women and 3 for men addresses the negative effects of excessive alcohol on bone formation and fall risk. For patients with excessive alcohol intake, reduction represents an important therapeutic target. Adequate protein intake supports both bone and muscle health. Recommendations suggest 0 to 1, 2 grams per kilogram body weight daily for older adults, which is higher than general adult recommendations. Protein provides amino acid substrate for bone matrix synthesis and is essential for muscle protein synthesis to maintain muscle mass and prevent sarcopenia. Older adults with inadequate protein intake, whether due to appetite changes, dental problems, social factors, or economic constraints, may benefit from nutritional counseling and potentially protein supplementation. Adherence to non-pharmacologic interventions presents challenges that parallel those observed with pharmacologic therapy. Exercise participation declines over time in many patients, with barriers including pain, fatigue, lack of time, absence of perceived benefit, and difficulty accessing appropriate programs. Calcium and vitamin D supplementation adherence varies considerably. Strategies to enhance adherence include individualized education, addressing personal risk and intervention rationale, goal setting and self-monitoring, group-based programs providing social support and accountability, regular follow-up and reinforcement, and addressing specific barriers identified through patient assessment. For rehabilitation and allied health professionals, non-pharmacologic interventions represent core competencies that can be implemented directly in clinical practice. Physical therapists are uniquely positioned to design and supervise exercise programs tailored to individual patient needs, incorporating bone-loading activities, resistance training, balance exercises, and spine-safe modifications as indicated. Occupational therapists contribute expertise in home safety assessment, environmental modification, and activity adaptation that reduces fall risk and supports functional independence. Nurses and other allied health professionals provide patient education, monitor adherence, and coordinate multidisciplinary care. Throughout the intervention process, recognition that non-pharmacologic approaches complement rather than replace pharmacologic therapy for patients at elevated fracture risk ensures comprehensive management. Now let's address special populations and health disparities. Osteoporosis management requires careful adaptation for special populations whose unique characteristics influence fracture risk assessment, treatment selection, and anticipated outcomes. Patients with chronic kidney disease, diabetes, mellitus, frailty, and those from racial and ethnic groups affected by healthcare disparities present distinct clinical challenges that demand individualized approaches informed by current evidence. Let's begin with chronic kidney disease. CKD profoundly affects mineral metabolism and bone health through mechanisms that distinguish it from primary osteoporosis and require modified diagnostic and therapeutic approaches. As kidney function declines, the ability to convert 25-hydroxyvitamin D to its active form, 1,25-dihydroxyvitamin D, diminishes. This leads to reduced intestinal calcium absorption and secondary hyperparathyroidism, with increased parathyroid hormone secretion. Elevated PTH stimulates bone resorption to maintain serum calcium, contributing to bone loss. Additionally, phosphate retention, metabolic acidosis, and accumulation of uremic toxins further compromise bone health through multiple mechanisms. The resulting bone disorder, termed chronic kidney disease mineral and bone disorder, or CKD-MBD, encompasses a spectrum of pathology. This ranges from high turnover osteitis fibrosa, characterized by excessive PTH-driven remodeling, to low turnover adynamic bone disease, characterized by suppressed remodeling and impaired bone formation. For patients with CKD stages 1 through 3, meaning estimated glomerular filtration rate of 30 milliliters per minute or higher, standard osteoporosis diagnostic and treatment approaches generally apply. DXA-measured BMD retains predictive value for fracture risk, and approved osteoporosis medications demonstrate efficacy. Bisphosphonates, Denosumab, and anabolic agents have been studied in patients with mild to moderate CKD and appear effective. However, bisphosphonate dose adjustment may be considered in stage 3 CKD, and these agents are generally not recommended when eGFR falls below 30 to 35 milliliters per minute due to renal accumulation. For patients with CKD stages 4 and 5, meaning eGFR below 30 milliliters per minute, the complexity of CKD-MBD pathophysiology complicates management. DXA-measured BMD becomes less predictive of fracture risk in advanced CKD. Distinguishing between osteoporosis and other forms of renal osteodystrophy may require bone biopsy in selected cases. Denosumab offers an important therapeutic option for patients with advanced CKD because it is not renally cleared and can be used across all stages of kidney disease. However, the risk of hypercalcemia is substantially increased in patients with CKD, particularly those with eGFR below 30 milliliters per minute. This is due to impaired ability to compensate for the calcium-lowering effect of potent anti-resorptive therapy. Management requires careful calcium and vitamin D optimization before initiating denosumab, with close monitoring of serum calcium following each dose. Now let's discuss diabetes mellitus. Type 2 diabetes presents a paradox in osteoporosis assessment. Despite often normal or even elevated bone mineral density, patients with diabetes experience significantly increased fracture risk. This discordance between BMD and fracture risk reflects adverse effects of diabetes on bone quality that are not captured by densitometric assessment. Chronic hyperglycemia promotes formation of advanced glycation end products, or AGEs, that accumulate in bone collagen. This alters collagen's mechanical properties and reduces resistance to fracture. Diabetic complications, including peripheral neuropathy, retinopathy, and cardiovascular disease, increase fall risk. Diabetes-associated sarcopenia and obesity further complicate the clinical picture. Standard T-score thresholds underestimate fracture risk in patients with type 2 diabetes. This has led to recommendations from some guideline bodies to consider treatment at T-scores of -2, 0 or higher in this population. The American Diabetes Association recommends incorporating diabetes status into fracture risk assessment and recognizing that patients with diabetes and T-scores in the osteopenic range may warrant treatment. FRAX may underestimate fracture probability in diabetic patients. Adjustment using trabecular bone score or application of rheumatoid arthritis as a surrogate risk factor has been proposed to better capture actual risk. First-line pharmacologic options for osteoporosis in diabetes include Bisphosphonates and Denosumab, which appear effective in this population. Remodeling requires careful consideration given the high prevalence of cardiovascular comorbidities in patients with diabetes and the cardiovascular safety concerns associated with this agent. Frailty represents a state of increased vulnerability to stressors that results from cumulative decline across multiple physiological systems. It strongly influences osteoporosis management considerations. Frailty and osteoporosis frequently coexist with shared risk factors including aging, physical inactivity, nutritional deficiencies, and chronic inflammation contributing to both conditions. The bidirectional relationship between frailty and fracture creates a cycle of vulnerability. Frailty increases fall risk and fracture probability, while fractures accelerate functional decline and worsen frailty. Sarcopenia, the age-related loss of muscle mass and strength, commonly accompanies osteoporosis and has been termed Osteosarcopenia when both conditions are present. Pharmacologic treatment of osteoporosis retains efficacy in frail older adults. Subgroup analyses from major clinical trials demonstrate similar relative fracture risk reductions in frail and non-frail populations. However, treatment decisions in frail patients require careful consideration of life expectancy, competing health priorities, medication burden, and goals of care. For patients with limited life expectancy, generally estimated at less than 1 to 2 years, the benefits of initiating osteoporosis pharmacotherapy may not be realized. Prioritization of comfort and quality of life may take precedence. Conversely, for frail patients with reasonable life expectancy who are at very high fracture risk, pharmacologic treatment can prevent fractures that would otherwise accelerate decline. Non-pharmacologic interventions are particularly valuable in frail populations. Exercise programs tailored to functional capacity can improve strength, balance, and mobility while reducing fall risk. Even modest improvements in physical function may have meaningful impact on fracture prevention and quality of life in frail individuals. Nutritional optimization, including adequate protein and vitamin D intake, supports both bone and muscle health. Fall prevention strategies addressing multiple risk factors are essential given the high fall propensity in frail populations. Osteoporosis in men has historically received less attention than in women, despite substantial disease burden. Approximately 1 in 4 men over age 50 will experience an osteoporotic fracture during their remaining lifetime. Men who sustain hip fractures have higher mortality rates than women, yet are less likely to be screened, diagnosed, or treated for osteoporosis. Secondary causes of osteoporosis are more prevalent in men than in women. Hypogonadism, including that induced by androgen deprivation therapy for prostate cancer, glucocorticoid use, and excessive alcohol consumption represent common contributors. Screening recommendations for men are less well established than for women. However, most professional organizations recommend DXA screening for men at age 70 or older, as well as younger men with clinical risk factors. Treatment approaches for osteoporosis in men parallel those in women. Bisphosphonates, Denosumab, and anabolic agents are all approved and demonstrated effective in male populations. Testosterone replacement may be considered in men with documented hypogonadism as a contributor to bone loss. though this approach addresses the underlying cause rather than directly treating osteoporosis. Additional osteoporosis therapy is often warranted. For men receiving androgen deprivation therapy for prostate cancer, prophylactic osteoporosis treatment with Denosumab or Bisphosphonates is recommended given the rapid bone loss and fracture risk associated with this therapy. Racial and ethnic disparities in osteoporosis care represent a significant healthcare equity concern. Black and Hispanic patients are substantially less likely than white patients to receive screening, diagnosis, and treatment despite experiencing meaningful fracture, morbidity, and mortality. These disparities persist after controlling for socioeconomic factors and insurance status. This suggests that healthcare system factors, provider behaviors, and the structure of screening recommendations contribute to inequitable care. The use of race-specific FRAX calculations results in lower calculated fracture probabilities for Black and Hispanic patients, potentially leading to fewer treatment recommendations. While these adjustments reflect observed differences in fracture rates, they may perpetuate a cycle of undertreatment in populations already experiencing healthcare disparities. Multiple factors contribute to disparities in osteoporosis care. Black and Hispanic women are underrepresented in osteoporosis research, limiting the evidence base for their treatment. Provider implicit bias may influence screening and treatment recommendations. Patient-level factors, including health literacy, cultural beliefs about bone health and medications, language barriers, and competing health priorities affect engagement with osteoporosis care. Structural barriers, including lack of access to DXA facilities, inadequate insurance coverage, and absence of regular primary care relationships, further impede appropriate screening and treatment. Strategies to address disparities include implementation of standardized screening protocols that ensure all eligible patients are offered bone density testing regardless of race. Integration of fracture liaison services that systematically identify and treat patients presenting with fragility fractures is also important. Provider education regarding implicit bias and cultural competency, along with patient education materials adapted for diverse cultural backgrounds and language needs, can help. Questioning the appropriateness of race-adjusted FRAX calculations and considering use of non-race-adjusted calculations for minority patients may help ensure that treatment thresholds do not perpetuate undertreatment. Community outreach and engagement can raise awareness of osteoporosis in communities where it may not be recognized as a significant health concern. For rehabilitation and allied health professionals, recognition of special population considerations supports appropriate clinical reasoning and care coordination. Patients with CKD may require modified exercise prescription and monitoring for treatment-related hypercalcemia. Diabetic patients benefit from attention to neuropathy and fall risk as components of fracture prevention. Frail patients require individualized balance of pharmacologic and non-pharmacologic approaches within the context of their overall goals. Male patients should not be overlooked for osteoporosis assessment, particularly those with secondary risk factors. Recognition of disparities enables advocacy for equitable care and culturally appropriate patient education across all populations encountered in clinical practice. Now, let's discuss adherence, multidisciplinary care, and fracture liaison services. These elements represent critical determinants of osteoporosis treatment success, yet both remain substantial challenges in clinical practice. Despite the availability of effective pharmacologic agents that significantly reduce fracture risk, poor adherence substantially limits real-world outcomes. Studies demonstrate that only 30 to 50% of patients remain on oral bisphosphonate therapy at 1 year. This is a sobering statistic that highlights the gap between what our medications can achieve and what they actually achieve in practice. Fracture liaison services have emerged as the leading model for addressing the care gap between fracture occurrence and treatment initiation. There is growing evidence supporting their effectiveness in improving screening, treatment, and outcomes. The magnitude of the adherence problem in osteoporosis management is substantial and has significant clinical consequences. Medication possession ratios, meaning the proportion of days covered by dispensed medication, frequently fall below the 80% threshold generally considered necessary for clinical benefit. Non-adherence is associated with significantly higher fracture rates compared with adherent patients. Studies demonstrate 30 to 40% higher fracture incidence in non-adherent populations. Beyond individual patient harm, poor adherence undermines the economic value proposition of osteoporosis treatment. The cost-effectiveness calculations that support treatment recommendations assume reasonable levels of medication taking. Multiple factors contribute to medication non-adherence in osteoporosis. Understanding these factors is essential for developing effective intervention strategies. Patient beliefs about medications, particularly concerns about adverse effects and skepticism regarding necessity, strongly influence adherence behavior. The asymptomatic nature of osteoporosis until fracture occurs makes it difficult for patients to perceive treatment benefit. This differs from conditions such as pain or hypertension, where symptomatic response reinforces medication taking. Concerns about adverse effects, particularly gastrointestinal symptoms with oral bisphosphonates, and rare but publicized complications such as osteonecrosis of the jaw and atypical femoral fractures, contribute to reluctance and early discontinuation. The complexity of oral bisphosphonate administration requirements presents a practical barrier to adherence. Patients must take these medications on an empty stomach with a full glass of plain water, remain upright for 30 to 60 minutes, and delay eating or taking other medications during this interval. For patients with busy morning routines, mobility limitations, or multiple medication requirements, these constraints may be burdensome and incompatible with daily life. Additionally, inadequate patient education regarding the importance of osteoporosis treatment, insufficient follow-up to monitor and reinforce adherence, and fragmented care with poor coordination between specialists and primary care providers all contribute to suboptimal medication taking. Evidence-based strategies to improve osteoporosis medication adherence address these barriers through multiple complementary approaches. Patient education that is individualized, interactive, and addresses both the pathophysiology of osteoporosis and the patient's personal risk profile has demonstrated effectiveness in improving adherence. Education should include clear explanation of how osteoporosis medications work, realistic discussion of expected benefits and potential side effects, proper medication administration technique, and strategies for managing common adverse effects. Shared decision-making that engages patients as active participants in treatment selection can enhance commitment to the chosen regimen. Regimen simplification through selection of less frequently dosed medications may improve adherence. Weekly bisphosphonate dosing is associated with better adherence than daily dosing, and monthly oral bisphosphonate formulations may offer further advantage. Injectable agents administered at extended intervals, such as Denosumab every 6 months or zoledronic acid annually, eliminate the daily or weekly burden of oral medication and the associated administration complexity. For patients who have difficulty with oral bisphosphonate administration or who demonstrate poor adherence to oral therapy, transition to injectable agents may improve persistence while maintaining or enhancing fracture protection. Monitoring strategies, including bone turnover markers and follow-up DXA, can provide objective feedback that reinforces treatment response and may enhance adherence. Bone turnover markers, measured at 3 to 6 months following treatment initiation, demonstrate biochemical response to therapy before BMD changes are detectable. This provides early reassurance that the medication is working. Follow-up DXA at appropriate intervals, typically 1 to 2 years after treatment initiation and periodically thereafter, documents BMD stability or improvement, reinforcing the value of continued therapy. Electronic monitoring, reminder systems, and structured follow-up programs have shown benefit in some studies and may be particularly valuable for patients at high risk of non-adherence. Fracture liaison services represent the leading model for systematic secondary fracture prevention. They address the well-documented care gap between fragility fracture occurrence and appropriate osteoporosis evaluation and treatment. The traditional approach in which fracture patients are treated surgically and discharged without osteoporosis assessment leaves the majority without treatment that could prevent future fractures. FLS programs systematically identify patients who have sustained fragility fractures, provide comprehensive assessment including BMD testing and evaluation for secondary causes, initiate or recommend osteoporosis treatment, and provide longitudinal follow-up to monitor adherence and outcomes. Core components of effective FLS programs include systematic case identification through integration with emergency departments, orthopedic services, and hospital admission processes to capture or fragility fracture patients. Assessment protocols evaluate BMD, fracture risk factors, secondary causes of osteoporosis, and fall risk. Treatment initiation may occur directly within the FLS, which improves initiation rates compared with referral to primary care, or through structured recommendation to primary care providers with close follow-up. Longitudinal monitoring for 2 to 5 years following fracture ensures ongoing adherence support and management of treatment transitions. The evidence supporting FLS effectiveness has grown substantially. Meta-analyses demonstrate that FLS significantly increases rates of BMD testing, treatment initiation, and medication adherence compared with usual care. A large Norwegian stepped wedge cluster randomized trial involving over 100,000 patients demonstrated that FLS implementation was associated with significant reductions in subsequent fractures and mortality in both women and men. These outcomes translate to meaningful clinical benefit and support continued expansion of FLS programs as a standard of care following fragility fracture. Implementation of FLS programs faces practical challenges, including resource requirements for dedicated coordinator positions, integration with electronic health records, and achievement of adequate reimbursement to support program sustainability. Various FLS models have been developed to accommodate different healthcare settings and resource availability. These range from intensive coordinator-led programs to lighter-touch approaches that leverage existing personnel and workflows. Innovations in FLS delivery include initiation of intravenous zoledronic acid during hip fracture hospitalization. This circumvents outpatient adherence challenges by delivering 1 year of treatment before hospital discharge. Multidisciplinary collaboration is essential for effective osteoporosis management, given the complexity of the condition and the multiple professional domains it encompasses. Nurse coordinators often serve as the backbone of FLS programs, managing patient identification, assessment coordination, education, and follow-up. Pharmacist involvement can enhance medication review, provide detailed counseling on proper administration and adverse effect management, and support adherence monitoring. Physical therapists and occupational therapists contribute expertise in exercise prescription, fall prevention, and functional assessment that complements pharmacologic management. Effective coordination across these disciplines ensures that the full range of osteoporosis management needs is addressed while avoiding fragmentation of care. For rehabilitation and allied health professionals, the extended therapeutic relationships characteristic of rehabilitation practice provide repeated opportunities to assess adherence, reinforce the importance of osteoporosis treatment, address concerns and barriers, and coordinate with prescribing providers. Brief adherence assessment can be incorporated into routine encounters using simple, open-ended questions such as, "How are you doing with your bone medication?" rather than leading questions that invite socially desirable responses. When adherence problems are identified, exploration of specific barriers enables targeted intervention. Motivational interviewing techniques can address ambivalence about treatment, while practical problem-solving can address logistical barriers. Recognition that adherence is not a fixed trait, but fluctuates over time, and in response to life circumstances, emphasizes the importance of ongoing attention rather than one-time assessment. Integration of adherence support into comprehensive care plans that address both pharmacologic and non-pharmacologic aspects of osteoporosis management reflects the multifaceted nature of fracture prevention. Patients who understand that their bone health depends on a combination of medication, exercise, fall prevention, and nutrition are better positioned to engage actively in all components of care. Regular reinforcement of this comprehensive approach, combined with systematic attention to adherence barriers, supports optimal outcomes across the continuum of osteoporosis management. Now, I would like to bring everything together through 3 comprehensive case studies that illustrate clinical decision-making across the spectrum of osteoporosis care. These cases will emphasize the role of rehabilitation and allied health professionals in optimizing outcomes. Our first case involves a 72-year-old postmenopausal woman with recent vertebral fracture and very high fracture risk. She presents to outpatient physical therapy following acute T8-T9 vertebral compression fractures sustained after a fall from standing height while reaching for an item on a high shelf. She reports chronic back pain that has worsened over the past several years, with progressive height loss of approximately 3 inches and increasing thoracic kyphosis. She lives alone in a 2-story home and has not previously been evaluated for osteoporosis. Her medical history includes hypertension controlled with lisinopril and hypothyroidism managed with levothyroxine. Physical examination reveals increased thoracic kyphosis with tenderness to palpation over the T89 region. Neurological examination is intact. Timed up and go test is 18 seconds, indicating elevated fall risk. She reports 2 falls in the past 12 months, both without injury prior to this event. Laboratory evaluation ordered by her physician reveals serum 25-hydroxyvitamin D of 18 nanograms per milliliter, which is deficient with otherwise unremarkable results. DXA reveals T-scores of -3.2 at the lumbar spine and -2.8 at the femoral neck. FRAX calculation incorporating BMD yields 10-year probability of major osteoporotic fracture of 35% and hip fracture probability of 12%. Both markedly exceed treatment thresholds. This patient meets criteria for very high fracture risk based on recent vertebral fracture, T-score below -3.0, elevated FRAX probability, and history of recurrent falls. Current guidelines recommend consideration of anabolic-first therapy for very high-risk patients, as this approach produces more rapid and substantial fracture risk reduction than anti-resorptive therapy alone. Options include Romosozumab for 12 months, followed by anti-resorptive consolidation, or teriparatide or abloparatide for up to 24 months, followed by anti-resorptive therapy. Given the absence of cardiovascular contraindications, meaning no history of myocardial infarction or stroke, Romosozumab represents a reasonable choice. It offers the advantage of dual anabolic and anti-resorptive effects with monthly rather than daily dosing. Vitamin D repletion is essential before and during therapy to optimize calcium homeostasis and treatment response. The physical therapy intervention plan addresses multiple domains of this patient's fracture risk and functional status. During the initial weeks following acute vertebral fracture, treatment focuses on pain management and gentle mobility within vertebral fracture precautions. Loaded spinal flexion and rotation should be avoided to reduce stress on compromised vertebrae, while extension exercises and postural training can begin as tolerated. As acute symptoms improve, progressive resistance training targeting lower extremity and trunk musculature is introduced, with attention to spine-safe positioning. Balance exercises address the elevated fall risk identified on assessment, progressing from static to dynamic challenges as competence develops. Gait training emphasizes safe mobility strategies for her home environment. Fall prevention interventions extend beyond exercise to address the environmental and behavioral factors contributing to her fall risk. Home safety assessment, which may be conducted by occupational therapy, identifies hazards including the reaching behavior that precipitated her fracture, inadequate lighting, and loose rugs. Education addresses safe reaching and carrying strategies, use of step stools with handrails, and environmental modifications to reduce hazards. Review of her medications with her physician confirms that her current regimen does not include high-risk psychotropic medications, though blood pressure medication timing may warrant discussion given potential orthostatic effects. At 12-month follow-up, this patient demonstrates significant improvement across multiple domains. Pain has decreased from 7 out of 10 to 2 out of 10. Functional mobility has improved with timed up and go, now 11 seconds, and independent ambulation without assistive device. She has experienced no falls since completing the fall prevention program. Repeat DXA shows 8% increase in lumbar spine BMD, consistent with expected response to anabolic therapy. She is transitioning to anti-resorptive therapy to consolidate gains and maintain long-term fracture protection. Her quality of life and confidence in daily activities have improved substantially. Our second case involves a 78-year-old man with type 2 diabetes, CKD stage 3B, and hip fracture. He is admitted to a skilled nursing facility for rehabilitation following surgical repair of right intertrochanteric hip fracture sustained in a fall at home. His medical history includes type 2 diabetes, mellitus diagnosed 15 years ago with current HbA1c of 7.8%, chronic kidney disease stage 3B with eGFR of 38 milliliters per minute, coronary artery disease with myocardial infarction 3 years ago, peripheral neuropathy with decreased sensation in both feet, diabetic retinopathy, and obesity with BMI of 31. Prior to his fracture, he was independent in all activities of daily living, ambulating without assistive device. DXA performed 6 months prior to his fracture revealed femoral neck T-score of -2.1, which by standard criteria would be classified as osteopenia. This case illustrates several important principles regarding osteoporosis management in complex patients. First, the occurrence of a fragility fracture confirms osteoporosis diagnosis regardless of BMD results, and this patient's hip fracture mandates treatment. Second, standard T-score thresholds underestimate fracture risk in patients with type 2 diabetes. The American Diabetes Association recommends considering treatment at T-scores of -2.0 or higher in this population. His T-score of -2.1, which might otherwise prompt only monitoring, actually indicates substantial risk in the context of diabetes. Third, his complex comorbidities significantly influence treatment selection. Pharmacologic agent selection in this patient requires careful consideration of multiple factors. Remodeling is contraindicated given his history of myocardial infarction within the past 3 years. Bisphosphonates require caution in CKD stage 3B, where they may be used with dose adjustment and monitoring, but are generally avoided when eGFR approaches 30 milliliters per minute. Denosumab offers an attractive option because it is not renally cleared and can be used across all stages of CKD. However, the risk of hypercalcemia is elevated in CKD patients, requiring careful calcium and vitamin D optimization before initiation, and close monitoring of serum calcium following each dose. Given his vitamin D deficiency, repletion therapy should precede Denosumab initiation. The rehabilitation intervention plan addresses this patient's multiple fall risk factors and functional deficits. Hip fracture rehabilitation follows standard progressive weight-bearing protocols per surgical guidelines, with transfer training and gait training adapted to accommodate his peripheral neuropathy and visual impairment. Strengthening exercises target hip and knee musculature bilaterally, with particular attention to the affected extremity. Balance training compensates for his reduced proprioceptive input from peripheral neuropathy and visual limitations from diabetic retinopathy, emphasizing alternative sensory strategies and environmental awareness. Occupational therapy assessment addresses adaptive equipment needs and home modification recommendations to reduce fall risk upon discharge. Coordination with the Fracture Liaison Service ensures systematic follow-up for BMD monitoring, pharmacotherapy management, and adherence assessment. His complex medication regimen and multiple comorbidities benefit from multidisciplinary coordination involving his primary care provider, endocrinologist, nephrologist, and rehabilitation team. Education addresses the relationship between his diabetes, kidney disease, and bone health, and the importance of comprehensive management across all these domains. At discharge from skilled nursing rehabilitation, this patient has achieved independence in transfers and ambulation with single-point cane on level surfaces. Denosumab therapy has been initiated with careful hypercalcemia precautions and calcium and vitamin D supplementation. Home safety modifications have been recommended and scheduled for implementation. The multidisciplinary approach optimizes his complex medical and functional needs while reducing his very high risk of subsequent fracture. Our third case involves an 85-year-old frail nursing home resident with dementia and recurrent falls. She is referred to physical therapy for fall prevention and mobility optimization following her 4th fall in 6 months, most recently resulting in a hip contusion without fracture. Her medical history includes moderate Alzheimer's dementia, osteoporosis diagnosed 4 years ago with the most recent DXA T-score of -2.9 at the femoral neck, major depressive disorder, and urinary incontinence. Current medications include oral alendronate, 70 milligrams weekly, initiated 5 years ago, sertraline, quetiapine, and oxybutynin. Nursing staff report difficulty with medication administration as she frequently has trouble swallowing pills and sometimes pockets medications in her cheek rather than swallowing them. She requires extensive assistance for ambulation, uses a wheelchair for distances greater than 50 feet, and is dependent in most activities of daily living. She has lost 8 pounds over the past 6 months. Laboratory evaluation reveals serum 25-hydroxyvitamin D of 15 nanograms per milliliter and albumin of 2.9 grams per deciliter. This case illustrates the complexities of osteoporosis management in frail older adults with cognitive impairment. Multiple management issues warrant attention. First, She has been on bisphosphonate therapy for 5 years, which typically prompts reassessment regarding continuation versus drug holiday. Her difficulty swallowing pills and uncertain adherence raise serious questions about whether she is receiving therapeutic benefit from oral alendronate. Second, her medication list includes 3 agents with significant fall risk: sertraline, which is an antidepressant; quetiapine, which is an antipsychotic; and oxybutynin, which is an anticholinergic. The anticholinergic additionally contributes cognitive burden in the setting of dementia. Third, her weight loss and low albumin indicate nutritional compromise that affects both bone and muscle health. Transition from oral alendronate to injectable therapy addresses the adherence challenges posed by her swallowing difficulty and cognitive impairment. Options include Denosumab, 60 mg subcutaneously every 6 months, or zoledronic acid, 5 mg intravenously annually. Either eliminates daily medication taking burden. Denosumab requires careful attention to hypocalcemia risk given her vitamin D deficiency and frailty, with calcium and vitamin D optimization and monitoring. If transitioning from alendronate, some residual bisphosphonate effect provides protection during the transition period. The choice between denosumab and zoledronic acid may consider facility resources, monitoring capacity, and patient and family preferences regarding injection frequency. Medication review with her physician addresses the multiple fall risk medications. Deprescribing discussions should weigh the fall risk reduction benefits of discontinuing or reducing psychotropic medications against the symptom management they provide. Quetiapine in a patient with dementia raises particular concern given both fall risk and potential adverse cognitive effects of antipsychotics in this population. Oxybutynin's anticholinergic properties warrant consideration of alternative approaches to incontinence management with lower cognitive and fall risk profiles. These discussions require careful consideration of quality of life, symptom burden, and goals of care in the context of her advanced dementia and limited life expectancy. Nutritional intervention addresses her weight loss and protein energy malnutrition. Protein supplementation supports both bone matrix synthesis and muscle protein synthesis to address the osteosarcopenia common in frail older adults. Vitamin D repletion through loading followed by maintenance dosing corrects her deficiency. Coordination with dietary services ensures adequate caloric intake and addresses any barriers to eating such as dental problems, food preferences, or assistance needs. The physical therapy program is tailored to her cognitive and physical limitations. Supervised exercise sessions emphasize seated and supported standing activities within her tolerance, targeting anti-gravity muscle strengthening and whatever balance challenges she can safely perform. Exercise sessions must accommodate her attention and memory limitations with simple, repetitive activities and immediate cueing. Caregiver and nursing staff education regarding safe transfer techniques and fall prevention strategies extends intervention benefits beyond formal therapy sessions. Evidence demonstrates that pharmacologic therapy retains fracture reduction efficacy in frail populations, with similar relative risk reductions observed in frail and non-frail subgroups of major clinical trials. This supports continued pharmacologic treatment in this patient despite her functional limitations. At the same time, her limited life expectancy and significant medication burden warrant honest discussion with her family and healthcare proxy regarding goals of care and the role of osteoporosis treatment within her overall care plan. At 6-month follow-up, this patient demonstrates modest but meaningful improvement. Falls have decreased from 4 in the preceding 6-month period to 1, likely reflecting the combined effects of exercise, medication review, and environmental modifications. Her weight has stabilized following nutritional intervention. She continues to require extensive assistance for mobility but maintains her baseline ambulation capacity. The multi-component approach addressing pharmacotherapy, full risk medications, nutrition, and tailored exercise has improved her outcomes despite the significant challenges posed by her dementia and frailty. These 3 cases illustrate the individualized, evidence-based approach that characterizes effective osteoporosis management across diverse patient populations. Each demonstrates the essential role of rehabilitation and allied health professionals in exercise prescription, fall prevention, patient education, adherence support, and multidisciplinary care coordination. the integration of pharmacologic and non-pharmacologic interventions, attention to special population considerations, and systematic approach to secondary fracture prevention through fracture liaison services represents contemporary best practice in reducing the substantial burden of osteoporotic fractures. Let me now bring this course to a close with some concluding thoughts. Osteoporosis represents one of the most significant public health challenges facing aging populations worldwide. Yet it remains a condition characterized by substantial gaps between evidence-based best practices and actual clinical care delivery. This course has provided a comprehensive, evidence-based update on osteoporosis management for physical therapists, occupational therapists, nurses, and the allied health professionals. We have synthesized the most current literature to equip you with the knowledge and clinical reasoning skills necessary to optimize patient outcomes. The foundational understanding of bone biology we discussed, including the dynamic interplay of osteoclasts, osteoblasts, and osteocytes within the remodeling cycle, the critical role of the Rankel OPG system, and the distinction between bone quantity and bone quality, provides the scientific basis for comprehending both the pathophysiology of osteoporosis and the mechanisms through which therapeutic interventions exert their effects. This knowledge enables rehabilitation professionals to explain to patients why their bones have become fragile, how medications work to strengthen them, and why mechanical loading through exercise stimulates bone formation through osteocyte-mediated mechanotransduction. The evolution of fracture risk assessment beyond bone mineral density alone represents a paradigm shift that has important implications for clinical practice. The integration of clinical risk factors through tools such as FRAX, the recognition that BMD accounts for only 60 to 70% of bone strength, and the emergence of the imminent fracture risk concept have refined our ability to identify patients who will benefit most from intervention. Contemporary pharmacologic management has been transformed by the emergence of anabolic-first treatment sequencing for very high-risk patients. This represents a fundamental shift from earlier approaches that reserved anabolic agents for treatment failures. The evidence demonstrating that prior anti-resorptive therapy blunts subsequent anabolic response, combined with data showing superior fracture reduction with anabolic-first approaches in very high-risk populations, has established sequential therapy as the standard of care for patients with recent fracture, very low BMD, or multiple risk factors. Rehabilitation professionals who understand these sequencing principles can support timely referral and reinforce the importance of completing anabolic therapy courses before transitioning to anti-resorptive consolidation. The non-pharmacologic interventions we examined, including exercise, fall prevention, nutritional optimization, and lifestyle modification, represent domains in which rehabilitation and allied health professionals possess primary expertise and can directly implement evidence-based care. The principles of mechanotransduction that underlie exercise-induced bone formation, the multi-component exercise programs that address bone, muscle, and balance simultaneously, the systematic approaches to fall prevention that reduce fracture-causing trauma, and the nutritional foundations of calcium, vitamin D, and protein intake all fall within the scope of rehabilitation practice. These interventions complement rather than replace pharmacologic therapy, and their integration into comprehensive management plans optimizes outcomes beyond what either approach achieves alone. The special population considerations we addressed highlight the importance of individualized care that accounts for patient-specific characteristics and comorbidities. Patients with chronic kidney disease require modified approaches that navigate the complexities of CKD MBD while still addressing fracture risk. Patients with diabetes experience fracture risk that exceeds what their BMD would predict, necessitating adjusted treatment thresholds. Frail patients benefit from continued pharmacologic therapy while requiring careful consideration of life expectancy, competing priorities, and goals of care. And the recognition of racial and ethnic disparities in osteoporosis care demands attention to healthcare equity and culturally appropriate patient engagement. Perhaps most importantly, this course has emphasized that effective osteoporosis management requires sustained attention to adherence and multidisciplinary care coordination. The sobering reality that only 30 to 50% of patients remain on oral bisphosphonate therapy at 1 year underscores the gap between treatment initiation and treatment success. Fracture liaison services have emerged as the leading model for systematic secondary fracture prevention, demonstrating that coordinated, team-based care significantly improves screening rates, treatment initiation, medication adherence, and ultimately, fracture outcomes. Rehabilitation professionals, through our extended therapeutic relationships with patients, are uniquely positioned to assess adherence, address barriers, reinforce medication importance, and coordinate with prescribing providers to optimize long-term outcomes. As healthcare professionals dedicated to restoring and optimizing function, we encounter osteoporosis across the full spectrum of clinical settings. This includes acute care following fragility fracture, post-acute rehabilitation, and outpatient and community-based practice focused on prevention and wellness. In each of these settings, the knowledge and skills developed through this course enable more effective clinical reasoning, more targeted interventions, and more meaningful contributions to the multidisciplinary teams that achieve the best outcomes for patients with or at risk for osteoporotic fractures. The burden of osteoporotic fractures, the mortality following hip fracture, the chronic pain and disability following vertebral compression, the loss of independence, and diminished quality of life that too often follow fragility fractures is not inevitable. Evidence-based screening identifies patients at risk. Effective pharmacologic agents substantially reduce fracture probability. Exercise and fall prevention address the mechanical forces that cause fractures. And multidisciplinary care coordination ensures that patients receive and persist with the treatments that protect them. By mastering the content of this course and applying it in clinical practice, rehabilitation and allied health professionals can make meaningful contributions to reducing the substantial human and societal burden of osteoporosis and its fracture consequences. Thank you for your attention throughout this course, and I wish you well in applying this knowledge to improve the lives of your patients. We will now review the exam questions to solidify your understanding. For each question, I will read the question aloud, provide the correct answer, and then explain the rationale behind that answer. This review is designed to reinforce the key concepts you have learned throughout this course on osteoporosis diagnosis, risk assessment, and management. Question 1. According to World Health Organization diagnostic criteria, osteoporosis is defined as a bone mineral density T-score at or below which threshold? The correct answer is -2.5. The World Health Organization established these diagnostic criteria in 1994, and they remain the gold standard for defining osteoporosis based on dual-energy X-ray absorptiometry measurements. A T-score compares an individual's bone mineral density to the mean of a healthy young adult reference population of the same sex. A T-score at or below -2.5 standard deviations indicates osteoporosis. T-scores between -1.0 and -2.5 represent osteopenia, which is low bone mass that has not yet reached the threshold for osteoporosis. Normal bone density is defined as a T-score of -1.0 or higher. Understanding these thresholds is essential for accurate diagnosis and for determining appropriate intervention strategies. Question 2. The FRAX tool calculates the probability of fracture over what time period? The correct answer is 10 years. FRAX, which stands for Fracture Risk Assessment Tool, is a computer-based algorithm developed by the World Health Organization Collaborating Center for Metabolic Bone Diseases. This tool integrates clinical risk factors with or without bone mineral density measurements to estimate an individual's 10-year probability of hip fracture and 10-year probability of major osteoporotic fracture. Major osteoporotic fractures include fractures of the hip, spine, forearm, and proximal humerus. The 10-year timeframe was selected because it provides a clinically meaningful period for treatment decisions and aligns with the duration of most pharmacologic intervention trials. Professional organizations use these 10-year probability thresholds to establish treatment guidelines, allowing clinicians to identify patients who would benefit most from pharmacologic intervention. Question 3. Which mechanism of action best describes how bisphosphonates reduce bone loss? The correct answer is inducing osteoclast apoptosis and reducing bone resorption. Bisphosphonates are anti-resorptive medications that have a high affinity for bone mineral and become incorporated into the skeletal matrix. During the normal bone remodeling process, osteoclasts resorb bone tissue, and in doing so, they release the bisphosphonate molecules that have been stored there. Once inside the osteoclast, bisphosphonates inhibit the enzyme farnesyl pyrophosphate synthase, which is essential for proper osteoclast function and survival. This inhibition disrupts the osteoclast's ability to form the ruffled border necessary for bone resorption and ultimately triggers programmed cell death, or apoptosis, of the osteoclast. By reducing osteoclast activity and survival, bisphosphonates decrease overall bone resorption, allowing bone formation to predominate and resulting in increased bone mineral density over time. Question 4. For patients at very high fracture risk, current guidelines recommend consideration of which treatment approach. The correct answer is anabolic-first therapy followed by anti-resorptive consolidation. This treatment sequencing strategy represents an important evolution in osteoporosis management. The American Society for Bone and Mineral Research and the Bone Health and Osteoporosis Foundation Task Force position statement specifically recommends considering anabolic-first therapy for patients at very high fracture risk. Anabolic agents such as teriparatide and romosozumab actively stimulate new bone formation rather than simply reducing bone resorption. In patients with severe osteoporosis or recent fragility fractures, anabolic therapy provides more rapid and substantial increases in bone mineral density and fracture risk reduction compared to starting with anti-resorptive therapy alone. Following the course of anabolic therapy, patients transition to anti-resorptive medications such as bisphosphonates or denosumab to consolidate and maintain the bone density gains achieved during the anabolic phase. This sequential approach maximizes the therapeutic benefits of both medication classes. Question 5. What's the recommended daily calcium intake from dietary sources and supplements combined for adults with osteoporosis? The correct answer is 1,000 to 1,200 milligrams. Adequate calcium intake is foundational for bone health and serves as an essential component of osteoporosis prevention and treatment. The recommended daily intake of 1,000 to 1,200 milligrams reflects guidelines from major medical organizations, including the National Osteoporosis Foundation and the Endocrine Society. Postmenopausal women and adults over age 70 are generally advised to aim for the higher end of this range at 1,200 milligrams daily. Importantly, dietary sources of calcium are preferred over supplements when possible, as food-based calcium provides better absorption and additional nutritional benefits. Common calcium-rich foods include dairy products, fortified plant-based milks, leafy green vegetables, and calcium-set tofu. When dietary intake is insufficient, calcium supplementation can help patients reach their daily target. Those supplements should be taken in divided doses of 500 milligrams or less to optimize absorption. Question 6. Which statement accurately describes the relationship between type 2 diabetes mellitus and osteoporosis? The correct answer is patients with diabetes have increased fracture risk despite often normal or elevated bone mineral density. Type 2 diabetes presents what is often called the diabetic bone paradox in osteoporosis assessment. Unlike the typical relationship where lower bone mineral density correlates with higher fracture risk, patients with type 2 diabetes frequently demonstrate normal or even elevated bone mineral density on densitometric testing, yet they experience significantly higher rates of fracture compared to individuals without diabetes. This paradox occurs because standard bone mineral density measurements capture bone quantity, but not bone quality. In diabetes, chronic hyperglycemia leads to the accumulation of advanced glycation end products within the bone collagen matrix, which impairs the mechanical properties of bone and increases its fragility. Additionally, diabetes affects bone through altered bone turnover, changes in bone microarchitecture, and effects on muscle function and fall risk. This understanding has important clinical implications, as healthcare providers can't rely solely on bone mineral density values to assess fracture risk in diabetic patients and must consider the diagnosis of diabetes itself as an independent risk factor. Question 7. What percentage of patients typically remain on oral bisphosphonate therapy at 1 year? The correct answer is 30 to 50%. Medication adherence represents one of the most significant challenges in osteoporosis management. Despite the proven efficacy of oral bisphosphonates in reducing fracture risk, real-world studies consistently demonstrate that only 30 to 50% of patients remain on therapy at the 1-year mark. This poor persistence substantially limits the effectiveness of treatment in clinical practice. Multiple factors contribute to non-adherence, including complex dosing requirements such as taking medication on an empty stomach, with a full glass of water and remaining upright for 30 to 60 minutes. Gastrointestinal side effects. The asymptomatic nature of osteoporosis, which reduces perceived urgency for treatment, and lack of tangible short-term benefits. The consequences of non-adherence are significant, with studies demonstrating that patients who discontinue or take their medications inconsistently experience substantially higher fracture rates. Strategies to improve adherence include patient education, simplified dosing regimens such as weekly or monthly formulations, injectable options, and regular follow-up. Question 8. What's a critical clinical concern when discontinuing denosumab therapy? The correct answer is rebound bone turnover and elevated risk of multiple vertebral fractures. Understanding the unique pharmacologic properties of denosumab is essential for safe prescribing. Unlike bisphosphonates, which accumulate in the bone matrix and continue to exert effects long after discontinuation, denosumab is a monoclonal antibody that circulates in the bloodstream and does not bind to bone. This means that the effects of denosumab are fully reversible once the medication is stopped. When denosumab therapy is discontinued, bone turnover markers rapidly increase to levels above pre-treatment baseline, a phenomenon known as rebound. This accelerated bone resorption leads to rapid bone loss, and most concerning, a markedly elevated risk of multiple vertebral fractures, even in patients who had not previously experienced vertebral fractures. Some patients have sustained 4 or more vertebral fractures within 1 to 2 years of stopping denosumab. For this reason, patients discontinuing denosumab must transition to bisphosphonate therapy to prevent rebound bone loss, typically starting within 6 months of the last denosumab injection. Clinicians must counsel patients about this risk and plan for appropriate transition therapy. Question 9. The concept of imminent fracture risk refers to elevated probability of fracture within what time frame following an incident fracture. The correct answer is 1 to 2 years. Imminent fracture risk is a critically important concept in contemporary osteoporosis management that has shifted clinical practice toward more aggressive early intervention. Research has demonstrated that patients who experience a fragility fracture have a substantially elevated probability of sustaining another fracture in the near term, defined as the subsequent 1 to 2 years. Studies show that approximately 20% of patients who sustain an initial fragility fracture will experience another fracture within 2 years, with the highest risk concentrated in the first 12 months following the index fracture. This understanding has profound clinical implications. It underscores the urgency of initiating osteoporosis treatment promptly after a fragility fracture, rather than delaying evaluation or treatment. It also supports the use of anabolic-first therapy in these high-risk patients, as anabolic agents provide more rapid fracture risk reduction compared to anti-resorptive medications. Fracture liaison services were developed specifically to capture these high-risk patients and ensure timely intervention during this window of imminent risk. Question 10. Which pharmacologic agent is an appropriate option for patients with advanced chronic kidney disease, specifically stages 4 through 5, because it is not renally cleared? The correct answer is subcutaneous denosumab. Chronic kidney disease presents unique challenges for osteoporosis pharmacotherapy because most bisphosphonates are primarily eliminated through renal excretion. When kidney function declines, bisphosphonates accumulate in the body, increasing the risk of adverse effects and potential nephrotoxicity. For this reason, bisphosphonates are generally not recommended when the estimated glomerular filtration rate falls below 30 to 35 milliliters per minute. Denosumab, however, offers an important alternative for patients with advanced chronic kidney disease because it is a monoclonal antibody that is metabolized through the reticuloendothelial system rather than being cleared by the kidneys. This allows denosumab to be used safely across all stages of kidney disease, including stages 4 and 5. However, clinicians must exercise particular caution regarding the risk of hypocalcemia, which is significantly increased in patients with chronic kidney disease due to their impaired ability to mobilize calcium stores and produce active vitamin D. Careful optimization of calcium and vitamin D status and close monitoring of serum calcium levels are essential when using denosumab in this population. Question 11. What is the primary function of osteocytes in bone remodeling? The correct answer is serving as mechanosensors that detect mechanical strain and microdamage. Osteocytes are the most abundant cell type in bone, comprising approximately 90% of all bone cells. Yet their critical role in bone biology has only been fully appreciated in recent decades. These cells are mature osteoblasts that have become embedded within the mineralized bone matrix during the bone formation process. Osteocytes reside in small spaces called lacunae and extend long cellular processes through tiny channels called canaliculi, forming an extensive interconnected network throughout the bone. This network functions as the skeletal mechanostat, detecting mechanical forces applied to bone during physical activity and weight bearing. When osteocytes sense mechanical strain or identify areas of microdamage in the bone matrix, they orchestrate targeted activation of bone remodeling by communicating with osteoblasts and osteoclasts on the bone surface. This ensures that bone is renewed in areas where repair is needed, and that the skeleton adapts its architecture in response to the mechanical demands placed upon it. Understanding osteocyte function has led to the development of new therapeutic targets, including sclerostin inhibitors like Romosozumab. Question 12. What is the primary purpose of fracture liaison services? The correct answer is systematically identifying and treating patients with fragility fractures to prevent subsequent fractures. Fracture liaison services represent the leading evidence-based model for systematic secondary fracture prevention. These programs address a critical gap in osteoporosis care known as the treatment gap, wherein the majority of patients who sustain fragility fractures are neither evaluated for osteoporosis nor treated to prevent future fractures. Fracture liaison services employ a coordinator-based approach, typically staffed by a nurse or other healthcare professional, who systematically identifies patients presenting with fragility fractures across healthcare settings including emergency departments, orthopedic clinics, and hospital wards. Once identified, patients receive comprehensive assessment, including bone mineral density testing via dual-energy X-ray absorptiometry, clinical risk factor evaluation, and laboratory testing to rule out secondary causes of bone loss. The Fracture Liaison Service then initiates or recommends appropriate osteoporosis treatment and provides longitudinal follow-up to monitor medication adherence and clinical outcomes. Research has consistently demonstrated that fracture liaison services significantly increase rates of osteoporosis assessment and treatment initiation while reducing the incidence of subsequent fractures and associated healthcare costs. This concludes our exam review for osteoporosis. Evidence-based update. Remember that understanding the pathophysiology of bone remodeling, recognizing risk factors, and the concept of imminent fracture risk, knowing the mechanisms and appropriate sequencing of pharmacologic agents, appreciating the importance of non-pharmacologic interventions, identifying special population considerations, and understanding the role of multidisciplinary care models like fracture liaison services are all essential for optimizing outcomes in patients with or at risk for osteoporosis. Thank you for completing this review, and best of luck on your examination.